Thank you very much, Jim, for that kind introduction. It really is a great pleasure, a privilege, and an honor to be here with you this afternoon to deliver this lecture associated with the Mendel Medal. As you can see from the first slide that's up on the board, I'm going to talk to you about a subject that I hope you do not think is too rash a statement to make, and that is ending the HIV/AIDS pandemic. I call it an achievable goal, and I hope that by the end of my presentation, I will have convinced you that under the circumstances that I will lay out for you, that you will agree with me that this is indeed an achievable goal, despite the fact that historically, as some of you and probably all of you know, that the HIV/AIDS pandemic is one of the most devastating scourges upon mankind, literally in the history of civilization, compared to things like the Black Plague of the 14th century, the influenza epidemic of 1918, the smallpox outbreaks, and the measles outbreaks. But before I do that, it's really a pleasure to be here on the campus of Villanova, and there's a considerable degree of affinity from where I think many of you came from or come from in your stage in your life, the students I'm referring to particularly, and really where I came from and how I got to where I am and how I got into the position, the privilege actually, of being able to address this most important disease. So first of all, I'm an Italian-American from Brooklyn, New York, and I had a training that I think that Gregor Mendel maybe would have been proud of. I went to elementary school, Our Lady of Guadalupe, in the Bensonhurst section of Brooklyn, New York. I had no idea at the time that I was there being taught by the Dominican nuns that I would be interested in science, because I was interested in a lot of things, mostly sports, but certainly not science at the time. I went to a very classical Jesuit high school in the middle of New York City called Regis High School, in which I was exposed very intensively to the humanities. So even in the ages of my early teens, I was actually much more interested in the humanities and people than I was in science as a particular discipline. And I think that's really important, because I often get asked by students when I talk at how did you get to the position that you're in now? Was it a linear thing that you knew about from the minute that you essentially came out of your mother's womb? Or was it something that were really circumstances beyond your control that actually shape what it is that you do with yourself? And as you'll see as I go on in this discussion, it really is very much the latter. Well, in school, one of my most important desires was playing basketball. So here's a picture of me as the captain of the Regis High School basketball team in New York City. I learned a very important lesson. I thought about this because I see from the Sports Illustrated that I read last night that Villanova is ranked 5th in the nation now, which is really terrific. At that time, I thought this is what I wanted to do with myself. But being a realist, I very quickly found out that a 5'7", really fast, good shooting point guard will never be as good as a really fast, good shooting 7-foot person. So I decided to change the direction of my career. And I went to Holy Cross College, another Jesuit college in Worcester, Massachusetts, and again studying the humanities with just about enough science to essentially kindle my desire, which was growing at the time, to be a physician. So I did what you do when you do Jesuit training. I studied Greek, Latin, French, and philosophy. Absolutely nothing to do with my future of HIV/AIDS in the coming years. So for the students who think that you may know you're on the right pathway of where you're going, doesn't always work out that way. In any event, let's get back to Gregor Johann Mendel, because one of the things I'd like to develop with you over the next few minutes is just some fundamental, simple observations in science often do not indicate what the ultimate impact of that was. And that's really what happened when we first started dealing with HIV/AIDS. We had no idea of where the science would bring us. And I want to bring that theme back to you of the science itself, the fundamental principles of science will allow us to make that somewhat brash statement on my first slide that ending this extraordinary scourge of a pandemic is really an achievable goal. So let's take a look at how we got there. I got into medicine, again, from a humanitarian standpoint, because when I went to college and then went to medical school, I had studied more classics and more philosophy than I did science, but enough science to get me into medical school, following which I did the usual training of multiple years of internal medicine training, and I became very fascinating with the discipline of infectious diseases. So I went to the National Institutes of Health in Bethesda, Maryland, and did a fellowship in infectious diseases and the interface between infectious disease and immunology. But I got waylaid on the way because I began to study diseases of autoinflammatory nature, and I was fortunate enough to be able to develop at a very young age, in my late 20s, what would turn out to be curative therapies, or at least highly remitting therapies for formerly fatal diseases such as some of the vasculitides. And I did that for a number of years from 1972 to 1981. But then, again, getting back to my oft-stated lessons for students and people at the student stage of their career, something happened completely beyond my control that totally transformed both my professional and my personal life. In June of 1981, the first of this paper saying pneumocystis pneumonia in Los Angeles landed on my desk in my office in the hospital in Bethesda, Maryland at NIH. And it described, interestingly, 5 young men, curiously all gay men, who came down with a strange type of pneumonia that is only seen in people who have dramatical suppression of their immune system. Now, I had been an infectious disease person following my training for the previous 9 years, because I came back to NIH after my training in 1972, and this is 1981. I thought it was a fluke. I put it aside on my desk, thinking that maybe this was some drug that they had taken that suppressed their immune system. And then 1 month later, my life changed, because what landed on my desk was the second publication from the Centers for Disease Control and Prevention. They called it MMWR, which stands for Morbidity and Mortality Weekly Report, a report that the CDC puts out every week surveilling the kind of diseases that come about. Now, this was not just 5 gay men. This was 26 men, again, curiously, all gay, not only from Los Angeles, but now from San Francisco and from New York, who presented not only with this strange pneumonia, but with a funny kind of extraordinary cancer called Kaposi sarcoma, as well as other opportunistic infections. And I decided that day in July of 1981, despite the fact that I had a very successful career up to that point studying inflammatory diseases, that I was going to completely turn around the tenure of my career trajectory. My mentors were very disturbed. They told me, why are you throwing away your career on a curiosity of a disease that's not going to develop into anything? Because at that time, there were less than 100 people having been reported with this new disease that didn't even have the name AIDS yet. It was called gay-related immunodeficiency because we mistakenly thought that it was only seen in gay men, which, as you'll see in a moment, is absolutely not the case. So I had to justify why it was that I was going to take this laboratory, which was my laboratory in 1981, and I was going to go turn it into admitting into the hospital these desperately ill men. So what I did is that I wrote, which I now refer to as my Apologia Pro Vita Sua. Now, for those of you who've taken Latin, an apologia pro vita sua is kind of an excuse or an explanation of what you're doing with your life. Apologia pro vita sua. And the reason I did that, because people thought I was crazy studying this strange disease. But I said something which, unfortunately, it's nice to know you're prescient, but it's sad to know that what you predicted actually came true. And what I said back then in 1982 was, because we don't know the cause of this syndrome, any assumption that it's going to remain restricted to a particular segment of our society is truly an assumption without scientific basis. When I wrote that, I sent it to the best medical journal, the New England Journal of Medicine. They rejected it because they said I was being too alarmist. So I sent it to another journal, the Annals of Internal Medicine, that actually accepted it. And unfortunately, those words became true, because over the next months to years, what we saw was a staccato reporting of the evolution in this country before we even knew that it was most prevalent in the developing world. We saw the disease among Haitians, among hemophiliacs who received protein transfusions of factors for their hemophilia, blood transfusion, babies born of infected mothers, heterosexual transmissibility. So what happened is that I began admitting these patients, and here's a picture of me literally in 1981-82 with one of the first patients that we were taking care of. I tried to do research on it, but I spent so much of my time taking care of desperately ill patients that we had very little to go back into the lab except in the middle of the night. So those are what I would consider probably the darkest years of my professional career, if not my entire life. So let's fast forward now. When I showed you this picture, there were 159 people reported with AIDS. I said AIDS, we weren't even calling it AIDS then, and we certainly didn't know what the etiologic agent was. So fast forward, we now know that there have been 80 million people infected, 37 million dead, another 37 million living with HIV, and each year there are 1 million deaths and 2 million new infections. In the United States, we've come to some degree of complacency because we have good drugs for the disease, which I'll get into in a moment. But there are 1.2 million people living with HIV. 12 to 13% don't know they're infected. I'll get back to that in a moment. 675,000 have died, and to our great shame, there have been 44,000 new infections each year for the last 15 years. So back in the early days of 80, it went up to maybe 125, 130, 140,000 new cases a year. Then it went down, and now it's stuck at 40 to 50,000 new infections. That's the bad news. The worst news is it's disparate. It is very heavily concentrated among African American men who have sex with men, who are bearing the greatest burden of the disease, and believe it or not, among very young people between 13 and 24, who account for 22%. So in December of just this past year, namely 2015, the New England Journal of Medicine asked me to summarize why I had been saying on TV and at different meetings that we actually can end the AIDS pandemic. And what I described in that article was that we actually followed the science, which is something that I believe that Gregor Mendel, were he alive today, would have been very pleased with. Because when we first started seeing patients, it was like swimming in the dark. We didn't have a clue. All we knew is that, at least in my career, where I had developed curative therapies for fatal diseases, and all of my patients who otherwise would have died were now doing extremely well. And we were on a real high, as it were. And then when we started studying these patients, all of our patients were dying, usually within a period of months to a year. How did we go from that complete dark years to where I am now at Villanova telling you we can end the AIDS pandemic. So let's talk about that. Following the science, I could spend my entire time talking about the breathtaking scientific advances that have occurred in each of the yellow boxes on this slide. This has led, believe it or not, over the years since 1981 to about 310,000 HIV-related papers. So if you go to PubMed right now and click in HIV, you'll get a list of 309,000 papers that have been published on this subject. And those papers have led to things that would have been unimaginable in the beginning. But I want to spend a couple of minutes on one of those since I don't have time to do them all, and that is treatment. So here again is a picture of me making rounds on my ward in the 1980s. As I told you, since patients came in late in their disease, when they would ask me, their parents, their loved ones, what this meant for them, tell me the truth, Dr. Fauci, what does this mean? How do people in my position do? What you'd have to tell them that most of the people, literally the median survival, which means 50% of the people, will be dead within 15 months. However, because we followed the science and looked at things like delineating the replication cycle of the virus, this is a little confusing slide for those of you not used to looking at that. It just shows you the steps in the replication of the virus as it enters a cell, replicates itself, and then comes out. What that particular knowledge of the cycle tells us is that there are multiple vulnerable targets that we could use to develop antiretroviral therapy. And that's exactly what we did over the years from the early 80s to the mid-90s. We started off with a single drug, AZT, which we screened that had already been developed as a not very good cancer drug, until we used targeted development to come up what we now have is 30 drugs that when used in combinations of 3 have completely transformed the field of HIV disease, such that, look at this evolution. In 1987, what we're measuring is the level of virus. So when the line goes down, that means the level of virus goes down in your body. In the horizontal axis is the duration of time. So in 1987, with one drug, we had a pretty good effect, but it didn't last. In 1994, with 2 drug combination, it was much better. And by 1996 up to today, we're able to suppress the virus to below detectable levels in people to the point where now, when the person in that same room that I showed you my talking to the patient, if a 25-year-old comes in newly infected with HIV and I put them on a triple combination of drug and they stay on that drug, I can now look them in the eye and tell them if they take their drug, they could live an additional 50 years, which if you look at the history of medicine over a period of 20 plus years until we got to that date, that's probably one of the most important translational advances in biomedical research of any disease, and that's where we are right now. So that's where the science of many, many people took us. Now, the next phase of my life came in, which I want to talk a little bit about, because I felt early on that we were not doing enough for HIV. So I did something that I probably would have said, no way would I ever do this. I took the job as the director of the National Institute of Allergy and Infectious Diseases in 1984. So I've been doing that now for 32 years. I didn't like the idea of administration, but I felt if I did that, I'd be able to have more of an impact, not only on the AIDS effort, but on global health in general. And that brought me into contact with things that I never ever would have imagined, nor certainly was I trained for
but I had to adapt very quickly. One of those was dealing directly over the last 32 years with 5 separate presidents. One of them had a major influence on what I'm going to talk about in a little bit, but all of them were variably supportive of HIV. In the beginning, President Reagan did not, in my opinion, put enough emphasis in using the bully pulpit of the presidency to call attention to the needs. But when we got to George H.W. Bush, he realized that and met with me multiple times, and that's how the support for HIV/AIDS accelerated greatly in the late 1980s when he became president in 1989. We'll get back to that and other presidents in a moment. But one of the things that we were able to come out of this was what was the president's emergency plan for AIDS relief. Now, some of you may not have heard of that, but what it is the biggest and most important global health endeavor ever embarked upon by any country, anywhere. And here is how it started. In a probably not very predictable way. In 2002, President George W. Bush called me into the Oval Office and said that he felt strongly that we needed, as a rich country, to be able to do something, and we have a moral obligation for those living in the world, in the developing world, where they don't have the resources to save their lives when we now have drugs that can do it. Because remember from the previous slide, I showed you that by 1996, 97, we turned around HIV. However, if you lived in the developing world, you didn't have access to those drugs. So he sent Tommy Thompson, here's a picture of Secretary Thompson, who was the secretary of HHS at the time. He sent us to Africa to visit a number of countries to ask the question, can we put together a program that can get treatment, prevention, and care to people living in the developing world where in 1981, we thought it was only gay men in the United States, but in reality, 91% of all the HIV infections are in the developing world, and 67% of them are in Southern Africa. Just think about that, 67% of all HIV infections are in Southern Africa. So we visited these countries, and I asked the question, at every country that I went to, because the president had asked me, can we make an investment that would be meaningful? So the question I asked was that if we gave them drugs, would they really be able to deliver it? And would the people take it? And there were many people, and I think it was probably racially tinged, that felt that you could never do that in Africa. We'd never be able to get drugs there and have people drugs. It turns out that wasn't the case. So here's a picture of me in a hospital. They were in the same boat in 2002 that I was in 1981. Only I didn't have any drugs to give anybody. Now the world had drugs, but they weren't giving it to them. So their patients were dying the same way mine were in 1981, but there was no need for them to die because we had drugs that could put them into remission. So I went into the bush. This is a 19-year-old girl from the AIDS Service Organization in Uganda who took me with her into the bush. I'm following in a Land Rover I didn't really want to get on that motorcycle with her in Africa. So I'm following her into the bush, into villages where we delivered drugs. 5 children in this picture were infected. All of the mothers of the kids were infected. We gave them drugs and we completely turned it down. So I came back in April of 2003 and I told the president that we can do this, but it's going to cost billions of dollars. And to his great credit, as well as the credit of people on his staff, that you've never heard of, people like Josh Bolton, who was the White House Chief of Staff and the Deputy Chief of Staff at the time, allowed me the access to work in the White House for 7 months from May of 2002 until December to put together a program which we ultimately decided to call the President's Emergency Plan for AIDS Relief, which was $15 billion over 5 years to prevent 7 million infections, treat 2 million people, and care for 10 million. He announced it in the State of the Union address in January 28th of 2003, and since then, there have been 17 million people put on ART, which has saved 8.8 million deaths that have been averted since 2000. So that's something that the United States of America really should be very proud of, because we had the leadership in the White House that allowed us to do that. So right now, if you look at the number of people on antiretroviral therapy, the results are striking. So having said that, there was a decline now of 43% in deaths since 2003 based on that program. So let's get back now to the prediction or the goal that I want you to believe that we can reach. If you treat all people with HIV, offer antiretroviral drugs and additional prevention for people at substantial risk, that's the recommendation. But it isn't completely happening. So how can we make that happen? What is the formula for doing that? The formula is that the foundation for HIV treatment and prevention events is HIV testing. You gotta test people first. And here's the paradigm that we created. If you test someone, there's only 2 possible results. They're either HIV positive or they're HIV negative. If they're HIV positive, they come into what's called a care continuum. What do we mean by that? A care continuum is from the time you're infected to the time you're on therapy and your viral load is below detectable level, which will save your life, but will also, as I'll get to in a moment, will prevent you from infecting anybody else because your level of virus is so low. So let's look at the care continuum in the United States, because it isn't really great. 12 to 13% of people don't know they're infected. So we know that 87% are diagnosed. If you go down to linking to care, retaining in care, and being virally suppressed, we're only about halfway there, and we're a developed country. Now, if you ask the question, who is infecting whom in the United States and in Puerto Rico? The numbers are really interesting. So 23% of those new 40 to 50,000 new infections each year are transmitted by somebody that doesn't even know they're infected. So they're inadvertently, innocently infecting somebody else, 23%. But here's an indictment of our healthcare system. 69% of the new infections come from someone who knows they're infected, but they're not in an adequate healthcare system to get treated. So if you do the math, it's pretty simple. If you diagnose everybody who's infected and you put them all on treatment, you could prevent 92% of all the infections in the United States. That's what I call an implementation gap. Now, the UNAIDS has developed an interesting formula, and I'll go through it with you very quickly. It's called 90-90-90. What do they mean by that? If you diagnose 90% of the infections in the world, and you put 90% of those on treatment, and of those, 90% are virally suppressed, what happens is that you can completely turn around the trajectory of the epidemic. Mathematical formulas and models tell you that, because 90% of 90% of 90%, what is that? 73%. Okay. So if you were able to do that, get 73% of the people virally suppressed, this is the target at 2015 that we'd like to get by 2020. So let's ask the question, how are we doing? We're not doing very well. We're at 38% instead of 73%. So we have a long way to go. Now, is it impossible to get there? I don't think so. Why? Because there are certain countries and certain regions that are doing that. Look at Botswana. Botswana is doing better than we are. They're at 70% and they're almost there. Sweden is the first country to actually get over 73%. It's a bit easier for them to have somewhat of a homogeneous society. They got a healthcare system that everybody gets into the system. But they're there. They're at 78%. Now, San Francisco is the flagship of the United States. They've decided that they're going to be very aggressive. So what they do is a program called the RAPID program. They go out into the community with homeless people, gay bars, wherever you want to go, and they test people with a test that you get the result in 20 minutes. So one of the problems is when you bring people in and test them, if they have to go home, a certain percentage of them don't come back. If you give them a prescription, a certain percentage don't fill it. If they fill it, a certain percentage don't take the medication. San Francisco does it a different way. They test you, you wait there. If you're positive, they give you a 30-day supply of the medication. And then they give you a prescription to come back. They get your cell phone number. If you don't have a cell phone, they give you a cell phone. So you're like a trapped population. Now, it's funny, but it's great, because if you look at the percent of people who have reached undetectable viral load, the gray line is if you just put them on therapy depending what their CD4 count is. The blue line is if you do it the regular way. The red line is what happens in San Francisco. Let's go quickly to prevention. When I first started getting involved in this in 1981, even before we knew what virus it was, the prevention modalities were low tech. We think it's a sexually transmitted disease. It's acting like one, even though we didn't know what it was. So use condoms. We know it's spread by blood, needle exchange, etc. Prevention isn't doing very well. And now the reason for that is that years ago, if somebody came into a clinic and was high risk, namely practicing risk behavior, and you tested them and they were negative, you'd say, "Whew, you dodged the bullet, thank you very much, have a nice day, go home." We don't do that anymore. If you're in a risk population, we put you in the same sort of continuum as if you were infected. We give you counseling, we provide prevention services, we retain you in services, and we make sure you adhere. Now, if you look at the middle yellow box, that's a toolkit that at first was only things like using condom, but now have a variety of medically related prevention modalities, including treatment as prevention. So let me spend 30 seconds on telling you what that is. It's a very interesting concept. Treatment as prevention means that if I am infected and you treat me and bring my viral load to below detectable level, you decrease by 97% the chances that I will transmit infection to someone else. That was a study that was done years ago, which now continues to show that it works in over 90% of the people. This is what happens when you treat somebody right away who's infected. That's the blue line. Look at the cumulative probability that that person is going to infect somebody else. Almost zero. Look at the red line. If you don't treat the person right away, the cumulative probability of their infecting somebody else goes way up. Now, if you look, let's go back for a second. You asked the question, well, that really works in a clinical trial. Does it really work in the real world? So you go to different cities and you say, if you increase the treatment in the city, does the incidence of infection go down? And no matter where you look, it happens. You go to Baltimore. The blue line is putting people on drug and suppressing the virus. As the blue line goes up, the red line, which is incidence, goes down. Go across the ocean to Rwanda. As the blue line goes up, the red line goes down. If you go to Europe and you study a large number of people who are in discordant relationships, namely, one is infected and the other one isn't, and you treat the infected partner, there were no documented infections within couple transmission. Over 58,000 sex acts with a median follow-up of 1.3 years. You know what that tells us? That tells us if you treat people, you can actually end the epidemic. Now, there's also pre-exposure prophylaxis. There are some people, by human nature alone, who continue to practice risk behavior. We now have what's called PrEP, or pre-exposure prophylaxis. You give somebody a single pill each day, and you could dramatically, and when I say dramatically as a biologist, I never say 100%. There's no such a thing as 100% in biology. But it's really darn close to 100%. And in fact, in a San Francisco study in which they put high-risk people on pre-exposure prophylaxis, among 1,200 men who were using PrEP, there were no new infections over a year and a half, whereas in the same clinic in which the men did not use PrEP, there were 82 new infections. That's rather stunningly dramatic data. If you go to Uganda and people are adherent to PrEP, you can decrease by 90% the HIV infection. Now, what's the problem? The problem is we're not doing a good job of disseminating this information, because we did a study in the United States and found out that there are over 1 million people who are at a substantial risk of HIV and should be counseled about PrEP. The problem is 1 out of 3 primary care doctors and nurses have never even heard of it. Again, an implementation gap. So I've been speaking to you now during this discussion about following the science and ending the HIV/AIDS pandemic. Now, I didn't mention vaccine because we don't have it yet. If we did, that would be the nail in the coffin of HIV. However, the point I want to close on in this last slide is that from what I've told you, and I hope you're convinced, that we now have the tools to end the HIV/AIDS pandemic if we only implement it. And I want to end with a slide which is a true story. I live in Washington, D.C., so I get the opportunity to go to a lot of dinners with people who are in big positions in government and the media. And I went to a dinner last December, the end of December, and I happened to be sitting down next to the editor of the editorial page of the Washington Post. And I gave him the lecture I just gave you. He was trying to eat his calamari. I wouldn't let him do it. I kept on talking to him about why we can end the AIDS epidemic. So he said, Tony, why don't you do me a favor? Why don't you write an opinion piece for the Washington Post? And I did. And in that, I essentially said what I've been telling you over the last 30 plus minutes. And that is, we really have no more excuses. We have the tools to end the HIV/AIDS pandemic. And I can tell you for sure that if we don't implement these tools that we already have, history is going to judge us very harshly. Thank you.
Zika.
Certainly.
Do you have a timeline for vaccine development, and realistically, would a vaccine take care of the problem?
So we started 5 vaccine candidates that are lined up for testing. We started the first one in August, an 80-person phase 1 trial for safety, because since it's a vaccine, safety is the most important thing. So we entered 80 people in it in clinics in Bethesda, Baltimore, and Atlanta at Emory. And it takes several months to see if it's safe. We'll know at the end of December. If it is, we'll go into a big trial in the developing countries that have it, like Brazil and Colombia and Puerto Rico, probably in the first quarter of 2017. We started the second vaccine trial of another candidate 3 days ago. You may have read it in the newspapers that we started it. So if we continue to have an outbreak, so in January and February, it's going to be Brazil's summer again. Right now, it's Brazil's winter, which is the reason why the infections went way down and why nobody got infected during the Olympics, because it was their winter. But coming up in January and February is going to be their summer. So if they get another big outbreak and we test the vaccine, we could potentially prove that it works by the middle of 2018. Well, we're not going to get a vaccine before then. We're lucky if we get it by 2018. But I really do think we will get a vaccine, because we've made successful vaccines for the first because Zika is in the same category of virus as dengue, West Nile, yellow fever. They're all the same. They're all dengue viruses.
Have you learned some lessons from these patients who had mutations in, say, the chemokine receptor, CCR5? Show a very quick slide there. And I'm curious to know whether the immune profile either HIV molecules that we could use, or the broadly neutralizing antibodies that are developed in these over a period of time that one could potentially use as a vaccine.
So, all about the vaccine, because that's a lack of a receptor, and that just is a good mechanism to get infected. The critical issue with HIV is that the body does not make an adequate immune response against this virus. If you look at every other disease that we've made successful vaccines against, smallpox, measles, polio, even though they have morbidity and mortality, ultimately the body clears the virus and you get lifelong protection against exposure to the same virus. Because the body does the proof of concept. It tells you, I can make a good response. For some reason that is still a mystery, the body doesn't make a good immune response against HIV. So the old adage that we vaccinologists would say, the best way to make a vaccine is to mimic natural infection. With HIV, that's not the case, because if you mimic natural infection, the body's not going to make a good response. So what we're trying to do is induce the body to make the kinds of response, be that neutralizing antibody or ADCC, that it doesn't make to natural infection. So the CCR5 deletion is a little bit of a red herring in that regard, because it doesn't tell you much about immunity. Right.
The San Francisco Rapid program is very impressive. What does it cost? Where do the funds come from? And what will it take on a large level in our country to bring about a similar program that reaches so many?
Right. That's a great question. Interestingly, it doesn't take an unattainable amount of money to do. It's the mobilization of many community people to go out into the community and do that. The cost of the drugs, we have the mechanisms in place. The Ryan White bill that pays for people who can't afford, Medicare, Medicaid. that will take care of the drug. The thing to do is to mobilize the community. It's not going to break the bank. You've got to just get the political. Andrew Cuomo in New York is trying to do the same thing, Governor Cuomo. I worked with him and his staff about trying to do a version of rapid in New York. Now, New York is a much more complicated place than the city of San Francisco, but they're at least going to try it in places like New York City.
Thank you for a fantastic talk. I love the theme of follow the science that came through. And as a chemist, something that bothers me, especially more recently in the last few years, is the pervasion in our society of anti-science. From anti-vaxxers who said if we have an AIDS vaccine, we could end it. But can you speak to me as a chemist or the students in the audience of what do we do in our conversations, in our lives, and speaking with people to try to combat this sentiment of not wanting to follow the science?
You know, if I had the answer to that. No, it's an easy question. It's a very difficult answer. You know, what I have found, one of the things I've had to deal with, some of you may forget or never saw, there was a period of time several years ago when I was almost continually on TV arguing against the anti-measles vaccine because people thought that measles vaccine was related to autism, which it clearly is not. And I found out that there's a certain proportion of people that if you carefully explain the data to them, that they will listen to it so long as you don't approach them in a pejorative way to make them feel like they're stupid. You can't do that. You've just got to be very open-minded. But there's a core group of people that no matter what you say, they are convinced of one thing, even though it completely goes against any scientific information. And those are the most difficult ones to deal with. I mean, it's just been really very, very tough to do that. And that's one of the things that I don't have a good answer for you for them.
Fauci, first, thank you so much for giving your lecture. I really enjoyed it. I noticed that one of your data point shows said most of the HIV epidemic was concentrated within youths, 13 to 24. I remember about a year ago, I was watching a documentary where they followed a girl living in like an impoverished community, I think somewhere in Louisiana, and she said she was born with HIV since she was 14. She had access to drugs, medication, and everything, but one of the reasons that she eventually stopped taking her medication was because a lot of the kids at school and the community made fun of her, and they sort of treated her as a diseased person for having HIV. How would you go about combating sort of this prejudice that I feel many members of the community would have against sort of looking at people living with HIV and AIDS as sort of like with disgust or like, I mean, they're sort of not seen, they're seen as like outside members of the community?
Yeah, so let me take you back to the earlier years when, first of all, stigma is still here, but stigma was totally rampant back in the 1980s, in the early years. I think just education and continuing in a rational way to try to explain to people that this is a disease like any other disease, and the social stigma associated with don't make any sense at all. We're doing much better now. Again, it's sort of an answer to the question that I just gave about the anti-science people. There are going to be some people that like to stigmatize no matter what. I don't think you can change them. You could embarrass them by having the bulk of society be against it. But we're doing much, much better right now in the acceptance of people who are HIV infected, particularly since they're doing so well right now. The issue is that in some countries, that stigma is still rampant, and that's one of the things that's going to prevent us from implementing some of the things that I said in my talk. You know, there are 90 countries throughout the world in which homosexuality is illegal. Could you believe that? I mean, amazing. 90 countries in which it's illegal to be gay. In Uganda, you can go to jail if you're gay. And you could even get a more profound punishment than that. That makes it really difficult, you know, to propagate open access to treatment and remove the fear of being treated and being recognized, because people associate it with things that they just cannot deal with in society. I mean, commercial sex work, injection drug use, sexuality itself, which is taboo in so many places. So again, it's not a satisfactory answer, except that we try our best to overcome stigma, but it's not always successful. Right.
You talked a little bit about how a country like Sweden is preventing HIV/AIDS. So why do you think that a country like the United States, which is also a very developed country, has such low numbers compared to a country like Sweden? And also, do you see stigma playing into that at all? Because in a place like Philadelphia, you have comparable HIV infection rates in certain areas of Philadelphia as a place like South Africa.
Right.
How do you see stigma playing into that, and how is there such a big difference between the United States and Sweden?
Yeah. I alluded to, that's a great question. I alluded to it quickly. Let me develop it a little bit for you. Sweden is essentially a homogeneous country. If you look at homogeneous in population, homogeneous ethnically, homogeneous healthcare access. So they've done a great job, and I don't want to take anything away from them. But when you have homogeneous things, there by definition is less stigma, because everybody's almost, the same. I mean, in many ways. I mean, obviously there's variability, polymorphism in populations, but it's not nearly as much. The United States is an extraordinary country. It's part of the beauty of our country, but it's also part of one of the liabilities that we have. Such discrepancies of economic discrepancies, racial discrepancies, access to healthcare discrepancies. For example, in our own situation, 50% of the new infections in the United States are among African American gay men, who are the most stigmatized people in society, even among their own African American population. So if you do studies in sociology, African Americans stigmatized among African Americans when they're gay is much greater than Caucasians stigmatized by Caucasian when they're gay. So even within a population you'd expect to be sympathetic, they're not. And then there's enormous discrepancies in access to health care. So Sweden is so different from the United States. So we've got to overcome that about us, which is part of the beauty of our country. To overcome that, we've got to do that if we really want to get to what Sweden is going to do. So late.
Is it a new virus that did not exist before?
Okay. Well, yeah. I'm going to give you an hour lecture in 30 seconds. Okay. It existed in chimpanzees and probably intermittently jumped species, because you don't need that many mutations to go from a chimp virus to a human. It's very, very similar. And probably in the 1910, 20, 30, it jumped species, and it likely jumped species because chimps were in Africa used as what's called bush meat. The people would kill chimps. It was a very important source of protein meat that they would eat. That was just part of the society. Nothing wrong with that. That's exactly what they did. And it is very likely that in butchering the chimps, somebody got cut and got infected. But when you're dealing with a situation in which the sociology of where you are, like if I got infected and I'm an African man who butchered a chimp, and I would infect my wife and I would get sick and die, and nobody would notice it, because there's so many other things there that are killing us. There's malaria, there's tuberculosis, there's everything else, you don't notice it.
But then when you get to the 60s and early 70s, with the dissolution of colonialism and a complete disruption of the sociology in the population, you had families disrupted, people living in the mines, commercial sex work, people going back to villages and getting people infected. That was emerged as an outbreak. It was kind of a perfect storm. So the virus was there for decades before we noticed it, namely when it started jumping species. Then it went from Africa, which is, we didn't know it was there, by a variety of ways of people who, I mean, the theory is that it came to the Americas because Haitians were sent as civil servant workers in some of the colonial countries, brought it back, and if you do what's called a phylogenetic tracing, if you look at the fingerprints of virus, how they mutate, you can track it where it was at a different time. So the tracking that has come about goes from Africa to the Caribbean, from the Caribbean to New York to the rest of the country, and then boom, explosion. That's how it happened. So it happened in the 20th century, but not before then, and only the sociological disruption that took place in the 60s with the dissolution of colonialism did it actually explode as well. That was more than 35 seconds, but it wasn't an hour lecture, right?
Hi, I have a slightly personal question. So you said in 1981 that was the darkest period of your life. Didn't really know what the disease was. What exactly got you through that period in your life, and how do you think you grew as a person, looking back?
Well, I think it was, well, there were several things. I mean, that's a deep question because it's, there are a lot of factors going into when I can tell you it was the darkest period of my professional life. It spilled over into my personal life. Because every day it's very difficult to take care of patients every single day that all die. But there were certain things that were the motivating force that got me to go on and not get burned out. One of them was the enormity of the problem and realizing that this was such a huge problem that we had to do something about it. We couldn't just wring our hands and say, oh my God, this is terrible. We had to do something about it. The other was the courage of the patients. The patients were amazing. I mean, the people that I took care of in those days and still do now were just amazing how they emerged with courage in a completely frightening situation. It's very, it's almost unprecedented in medicine when you're dealing with something that's a complete mystery. I mean, if you're an oncologist and you take care of patients who have cancer of the terrible type, you at least know what's going on. You're not curing them, but you know what's going on. When you're dealing in a situation where vibrant, attractive, really nice young, most of whom are all gay, are getting sick and dying in front of you, that's an amazing motivation to just do something about it. The issue is that we weren't able to actually do something that was meaningful for at least a couple of years. And those early years were the years that were horribly frustrating because we just felt like we were completely powerless.
Last question. Hi, so you talked about prep. How do you think that can be more well known and available to people in the hospital? Because I know personally, I'm a and they have a significant other
Yeah, I think we really need to be incredibly aggressive in talking about it all the time with public service announcements. The CDC is trying their best to get out there. Every time I talk about HIV, I never refrain from talking about PrEP all the time. And you just gotta keep going at it over and over and over again. And in fact, even though 1 out of 3 never heard of it, I could have showed you another slide, which I didn't, that over the last 3 or 4 years, it went from like 4 out of 5 that didn't know about it, now to 1 out of 3. So we're going in the right direction. And I think in a couple of years, almost everybody's gonna have heard about it.
Well, thank you all for being here, and most especially thank you, Dr. Fauci, for being at Villanova with us today.